Welcome to This Explainer. Today, we're putting on our medical detective hats. We're going to uncover the entire pathophysiology of a truly fascinating condition, Gaucher disease, and we're going to build it from the ground up, starting from one single, tiny, microscopic defect and working our way all the way up to systemic organ failure. All right, let's dive right in.
So, to set the stage here, I want you to imagine a patient. It's a young patient, and they present with bone pain that is so incredibly severe, it literally mimics a sickle cell crisis. You examine them, and you find a massively enlarged spleen. Then, you glance at their medical history, and you notice their growth curve has just been quietly dropping off track for years. So, what single molecular problem actually ties all these severe, seemingly completely unconnected symptoms together? I mean, 3 different specialists, an orthopedist, a hematologist, and an endocrinologist. They could all claim this exact case. But really, they'd all be looking at the exact same cellular recycling crisis.
The core culprit behind all of these clinical manifestations is, of course, Gaucher disease. It's an autosomal recessive lysosomal storage disorder. And this all happens because a very specific enzyme, glucocerebrosidase, is completely deficient. Now, in a normal scenario, this enzyme acts as the cellular cleanup crew, right? But here, its absence leaves the body's recycling system totally unable to do its job.
To see how this actually builds up at a cellular level, we really have to look at macrophages. These are essentially the garbage collectors of your blood. They're meant to engulf old red and white blood cells and break down those cellular membranes for recycling. But because that crucial glucocerebrosidase enzyme is missing, they just can't break down a specific lipid called glucosylceramide. So the trash gets in the door, sure, but it never actually gets broken down. Step by step, that undigested lipid just accumulates, and it accumulates, until the macrophage becomes massively overstuffed.
If you were to take a look at a bone marrow sample under a microscope, these overstuffed macrophages, which we now call Gaucher cells, they have a really distinct look. Their packed lysosomes actually make the cytoplasm look exactly like crumpled tissue paper. It's a striking, albeit pathological visual of a cell quite literally drowning in its own cellular waste. Section 1, the anatomical spread, the reticuloendothelial system. Let's keep moving. Okay, so now that we know exactly what a Gaucher cell is, we really need to understand why they cause such specific, severe symptoms. I mean, they don't just float around randomly, right? Gaucher cells accumulate exactly where normal macrophages live in the highest numbers. Our body's reticuloendothelial system is designed to filter blood and clear out aged cells. Therefore, macrophages live primarily in the spleen, the liver, and the bone marrow. So when these macrophages turn into those overstuffed Gaucher cells, they don't move. They just expand right where they are. And that is exactly why this single enzyme defect produces a clinical picture completely dominated by these 3 specific organs. Because of this highly targeted anatomical accumulation, the sheer scale of organ involvement is honestly staggering. Over 90% of patients develop splenomegaly. And, we aren't just talking about a slightly enlarged spleen here. We are talking about genuinely massive enlargement. And that's often accompanied by a similarly enlarged liver through the exact same infiltrative mechanism. But hey, the spleen and liver aren't the only places affected. Down in the bone marrow, this severe cellular infiltration causes what is arguably the most disabling aspect of the entire disease. Patients suffer from incredibly painful bone crises and avascular necrosis, particularly of the femoral head. It also completely disrupts normal bone remodeling. This leads to a classic radiological finding known as the Erlenmeyer flask deformity. So the normal tapering of the distal femur is just entirely lost. It gets replaced by this abnormal flask-like widening because the bone marrow is quite literally packed full of Gaucher cells. And that brings us to the systemic burden. Think about it. The marrow is getting packed, pushing out normal blood production. And that massive spleen? Well, it's sequestering, or essentially trapping normal blood cells. Working together, this double whammy leads to anemia and thrombocytopenia, so low red blood cells and low platelets, which directly and dangerously increases the patient's bleeding risk. And for children, the chronic systemic burden of this disease activity just totally drains the body's resources. That leads to severe growth retardation and delayed puberty. It's a devastating systemic drain happening during a child's absolute most crucial developmental years.
Section 2. Neurological types and diagnosis.
So to truly understand how this disease behaves, and more importantly, how we can actually medically engineer a solution, we have to categorize it based on one absolutely vital factor: central nervous system involvement. Type 1 is by far the most common form, particularly in the Ashkenazi Jewish population, and the key here is that it entirely spares the central nervous system. The disease is completely confined to those visceral, hematological, and skeletal organs we just walked through. Now, this contrasts super sharply with types 2 and 3, which involve genuine, severe neuronopathic disease. Type 2 is a rapidly progressive infantile form with terrible neurological deterioration, while type 3 has a slower, more chronic neurological course. Definitely keep that neurological distinction in the back of your mind. It literally dictates everything about our treatment strategy.
But first, how do we actually confirm this diagnosis? Clinicians aren't just guessing based on an enlarged spleen, right? For the initial diagnosis, they directly measure for deficient glucocerebrosidase enzyme activity in the blood. They pair that with genetic testing to look for very specific GBA1 mutations. Then, for ongoing monitoring, we track specific biomarkers. Elevated levels of serum to titreosidase and ferritin are just fantastic markers of overall disease burden and macrophage activation. They essentially tell us exactly how active the disease is and how well a patient is actually responding to their therapy.
Section 3. Engineering a treatment. Let's get into the solutions.
When it comes to treating this condition, we actually rely on two fundamentally different strategies. They're basically highly logical engineering solutions to fix our broken cellular recycling system. First up, we have enzyme replacement therapy, or ERT. This is an intravenous infusion that directly supplies the missing enzyme, effectively restoring the macrophage's capacity to break down the waste. Pretty straightforward. Alternatively, we have substrate reduction therapy, or SRT. Now, this is an oral pill that takes the exact opposite strategic approach. Instead of replacing the enzyme, it actually reduces the production of the cellular trash, that glucocerebrosidase entering the system in the first place. This eases the burden on whatever tiny bit of enzyme activity the patient might actually still naturally have.
Let's look a bit closer at ERT. For symptomatic type 1 Gaucher disease, enzyme replacement therapy is an incredibly effective, completely established first-line treatment. But why is it so good here? Well, because type 1 strictly affects visceral organs and spares the central nervous system. You see, ERT utilizes a massive recombinant enzyme that physically cannot cross the blood-brain barrier. But for type 1, that limitation, it doesn't matter at all. The entire disease burden is outside the brain anyway. Now, what about that oral option, the substrate reduction therapy? Well, these agents are definitely not all created equal. First, there's elaglustat. This is a fantastic first-line oral alternative to lifelong IV infusions. But, and there's a catch, it's specifically for adults who are compatible CYP2D6 metabolizers. Thankfully, that covers the large majority of patients, and emerging data is even starting to support its use in some pediatric cases too. On the flip side, we have miglustat. It's an older, noticeably less potent drug with a pretty distinct gastrointestinal side effect profile. Because of that, it is strictly positioned as a second-line therapy for adults who simply cannot tolerate the enzyme replacement.
Of course, beyond these highly targeted therapies, we still have to treat the patient's immediate, day-to-day pain. Supportive care includes strong analgesia for those excruciating bone crises, along with bisphosphonates for the bone disease. But what about a splenectomy? Actually removing that massively enlarged spleen used to be much more common, but today, it is strictly reserved as an absolute last resort. Why the shift? Because without a spleen, these patients face severe, long-term infection risks from encapsulated organisms. The goal now is to shrink the spleen medically, not remove it surgically.
Let's move to the vanguard of research for a second and look at what the future holds. Remember how ERT can't cross the blood-brain barrier, making it basically useless for the neurological symptoms of types 2 and 3? Well, scientists are actively investigating an incredible new drug called venglustat. This is a brain-penetrant substrate reduction agent that's currently in clinical trials. By actually crossing the blood-brain barrier, it could finally offer a way to treat the devastating neuropathic forms of this disease. It's addressing a massive unmet need that literally none of our current approved options can even touch.
So we've built the whole picture here. Splenomegaly, bone crises, bleeding risks, all of it stemming from a single, missing, microscopic enzyme. So the next time you encounter a confusing case of massive organ enlargement paired with severe bone pain, I want you to ask yourself a unifying question. Could understanding the disease from first principles lead you straight to the missing link? Could it simply be a cell that just can't take out its own trash? Thank you so much for exploring this really fascinating mechanism with me. Keep asking those big questions, and I'll catch you in the next explainer.